And welcome to this afternoon's GastroEcho program. GastroEcho, of course, is hosted by the Gastro Foundation in association with Project ECHO, University of New Mexico, and these sessions are held on a weekly basis every Wednesday afternoon. The chat will be open for questions, and this afternoon we've got two interesting cases related to some of the great work that Dr. Lala has been doing in terms of luminal gastroenterological lesion resection, the identification of these lesions both at the time of endoscopy and then looking at these specimens under the microscope. And then we had some interesting cases related to patients with iron overload recently, and we'll be showing one of those with Prof. Hale. So Vikash, I'm going to hand over to you and let you start your presentation.
Thanks, Bilal, for that kind introduction. So I'm just going to share some of the endoscopy and a little case vignette for a very interesting case and a very rare case. I must say it certainly caught me off guard. Very few cases described in the world, and I think even fewer managed endoscopically. Essentially, we did endoscopy for a 60-year-old male patient who was retroreactive, but was doing well on therapy. He was hypertensive and a type 2 diabetic with sober habits, non-smoker. But he did have end-stage renal disease and was on hemodialysis 3 times a week. He was dialyzing by an AV fistula. He had some issues. The fistula was a bit stenotic and he wasn't getting good clearance. But essentially, he was being worked up for renal transplant, and he had a gastroscopy done as part of his standard transplant workup. And the referring endoscopist found an atypical plaque in his upper esophagus at about 20 centimeters. And he also noted in his scope report a 5-centimeter fungating mass at about 20 centimeters from the incisors. So he proceeded to take some biopsies and then subsequently referred the patient to me for an endoscopic assessment and potentially an endoscopic resection, especially of that 5-centimeter fungating mass. And this is what the biopsy results showed from his specimens. Essentially, it showed the plaque that he described just showed chronic esophagitis with perikeratosis. And the fungating mass that he described was essentially assessed as a virally induced squamous papilloma. Just to note, though, no actual HPV stains were done, just a P16 stain was done. And there was no metaplasia, dysplasia, or malignancy from the biopsy specimen. But remember that is a superficial specimen. So I'm just going to share with you the endoscopy. This is the video that I made of the scopes that I did. I wasn't actually going to play the sound, but I think let's play the sound because I did do a sound overlay and it might actually be useful.
Hi, welcome. We're here in Joburg. We're doing a gastroscopy for a 60-year-old gentleman with end-stage renal disease who's been worked up for a renal transplant. He's on hemodialysis. He's also immune compromised. He had a screening gastroscopy as part of his workup, and they found a suspicious lesion in his esophagus. So we're just above or just below the upper esophageal sphincter, and you notice these multiple white plaques in the esophagus. And if you just interrogate these white plaques a little bit closer, let's go to near focus and NBI, you can see a very frond-like type of picture. And within the fronds, you can appreciate slightly dilated intrapapillary capillary loops. So this frond-like picture is almost warty-like, and it looks very much like what you would find with anal papillomas. So this looks very much like a HPV-related papilloma. However, the IPCLs are not very abnormal with regards to the Japanese endoscopic or esophageal.
So I'm just going to stop it there. I'm going to just take you through something before I continue, because what I know is that we're quite poor at assessing squamous mucosa. And I think we all know about the colon and columnar and kudos and sanos and all of those classifications, but this is something that's very poorly taught. And it's actually very valuable to the endoscopist. So I made mention of something called IPCLs, or intrapapillary capillary loops. And this is essentially equivalent to the pit pattern or the vascular pattern in the colon. Now, I do appreciate that it's very difficult to assess, and there's all of these tricky classifications, but they're very useful because they tell you the difference between dysplasia, they tell you the difference between cancer, and like in the colon for adenomas, they can tell you depth of invasion for carcinoma. So there's a whole lot of classifications, though. On top, you see A, that's the Inouye classification, B is the RISMA classification, and I agree, very confusing. It's very difficult to remember all of that. But what I do urge you to look up is at least C. So C is the Japanese Esophageal Society classification, the JES classification. Now, essentially what you're looking at is these little blood vessels. And you're looking at certain features of the blood vessels. Number one, tortuosity. Number two, you're looking at the caliber of the blood vessels. You're looking at the shape of the blood vessels, and you're looking at whether they're unfolded or not. And that's very, very useful in terms of making a diagnosis and also staging a patient with regards to T-stage. So you can then determine whether something is for endoscopic resection or whether it's too deep and it's going to require surgery. So normally you see nice tight vessels in a corkscrew type of appearance. These vessels tend to face the same direction, but as you start getting more abnormalities, what happens is these vessels start unfolding in a little loop-like formation. So B1, you see these little flowers, and that's usually early dysplasia or inflammation. And as you get progressive disease, what happens is these vessels start unfolding more. And then when they become nice and thick and dilated, like this large caliber vessel you see here, that's when you've missed the boat, because that's telling you that there's SM invasion, at least into SM2 level or deeper. And that's, of course, not going to be a great therapy or candidate for endoscopic therapy. So it can be very tricky, but it is quite a useful classification. These are just some examples, and you'll see in the scope that I perform. I'll go back to the video now. So this is B1, those little flowers. Then you start getting B2, these unfolded vessels, which is telling you that it's now an invasive malignancy. And then you get these large caliber B3s, and that's telling you it's going at least into SM2, if not deeper. So let's go back to the video.
Classification. If you look there, you can probably see slightly unfolded, slightly.
So these guys here are pretty
vessels.
much normal. They quite tight and corkscrew. But here you see these little flowers, the shorter, slightly unfolded ones. But that's usually just inflammation or could be early dysplasia.
You immediately see this lesion quite obvious staring at you. So the first thing you notice is a lot of bulk. But you also see that white plaque on the base surrounding that lesion. If you get closer to the lesion, and again interrogate it a little bit with near focus and the eye, again looks very frond-like, and difficult to actually appreciate any IPCLs on the lesion itself. So this looks quite concerning for a squamous papilloma with transformation with dysplasia and potentially malignancy as well. So we would refer this patient to see if he would be amenable to any sort of endoscopic resection. It's difficult to appreciate the IPCLs within the lesion itself. They don't particularly look abnormal, but if you look carefully at the center of the screen there, you can see again some unfolded, slightly unfolded IPCLs without that nice tight corkscrew that you normally see. A bit of trauma here. This is just from scope passage. It's not spontaneous bleeding. Fortunately, we don't have any iodine at the moment, so we're just going to assess this with narrow imaging.
So remember, in terms of trauma endoscopy, iodine is what you want to use for squamous.
A little bit more abnormal vessels. Now I'm starting to talk about P2 vessels. That's looking concerning for malignancy. Don't see those thick dilated vessels P3. So don't think it's deeply invasive. Lesion is a bit too large to think about and bulky to think about resecting with the DMR.
I'm just going to skip a bit forward, save a bit of time to show you the rest of the esophagus. So interesting in that these plaques were essentially found throughout the esophagus. And that's not commonly described with this type of lesion when Prof. Hale gets into it too.
In the eye. And you can see the plaque-like lesions are pretty much all over the esophagus. Here you see a little area of scarring, but at the area of scarring, IPCLs just look like inflammation, so that doesn't look like anything concerning.
Okay, so we found a lesion in the mid-esophagus that was very concerning for malignancy based on the IPCLs, but you didn't get those big dilated vessels, so we didn't think it was deeply invasive. And so I thought it was amenable to endoscopic therapy. And because it was quite large, the therapy of choice that I chose was a ESD. So I marked out the lesion quite carefully to get a nice wide margin around the plaque-like area. I opened up a pocket. I did the pocket creation method. So you can see that that's tunneling into the submucosal space. On the left, you see the muscularis propria. You beautifully see that inner circular layer. And that's your beautiful submucosa on the right. And that was the defect. It was remaining in the defect. You just see the inner circular layer. So dissecting as close as possible to the inner circular layer, of course, without trying to cause any muscle trauma. And that's the macro, or that's the specimen that came out. Try to orientate it with regards to which side is the anal end and the oral end, or the GOJ and the upper esophageal sphincter, just for Prof. Hale to be able to know if there is involvement of the margin, then we know exactly which margin is involved. That's it for me. Prof, I'll hand over to you.
Okay, thanks, Vikash. So, all right, so I'm going to show you. I've got a macro picture as well to share with you, and the reason I think that Vikash has given an excellent demonstration of the endoscopic features, and also what would be seen at the time of endoscopy and the resection. So what I want to do now is show you what we look at. So there is our picture, and you can see there. I'll just get the. There we are. So what we've got here is this ellipse of mucosa, as you can see there. In fact, really, it's almost a donut. And when I saw this, I thought, gee, I don't like the look of this. You can see that it's markedly elevated. There's a lot of superficial ulceration and almost sort of keratinous debris on the surface. You can see it's exfoliating. A couple of things going on here, which not really sure what that is. I think it's related to this. Now, the reason I wanted to show you this is the oral end here, but the reason I wanted to show you this was the difference between what Vikash has just shown you with the raw material, if you like, compared to what we see when it's fixed. And, you know, often surgeons say, oh, but, you know, there is this, whatever it might be, there was this spot or this area of discoloration. And Vikash, perhaps you could just put up your macro picture again, and we'll just toggle between the two, because I think, you know, people are we're quite surprised when we as histopathologists don't see what is necessarily seen at the time of surgery. So I'm going to stop sharing, and Vikash, just put that up again, if you wouldn't mind.
Give me a second. There we go. Yeah.
Okay, so you can see there that that's the real thing. You can see the natural color of the tissue. You can see the the variation in the blood supply. You can see areas of hemorrhage, and you can also see that whitish material, which is completely lost on the tissue once it undergoes formalin fixation. So we end up with pretty nondescript looking, grayish looking tissue most of the time. Okay, so thanks Vikash. So I'm going to go back now to the histology. So we put it through, and in fact, let me just go back to, I'm going to share another, go back to this again. So you'll remember that last time we did one of Vikash's endoscopic submucosal resections, I described how we take the blocks. And there's a particular way that these should be taken. The first and most important thing, there has to be excellent communication between the endoscopist and the pathologist, because if that communication is absent, then in fact the interpretation of the pathology really becomes useless. So it's very, very important that that the tissue is properly orientated. And when Vikash started doing these, we said, right, we pin it out on cork as he's got here. We orientate the oral end and the anal end, and then Vikash, and in fact, as endoscopies, you pick up the 3 o'clock position at endoscopy. And then when we get the tissue, we're then able to orientate it. So what happens is that we ink the reverse of this mucosa. I do this in black ink in the undersurface, which obviously you can't see. And then what I do at the in this particular instance, because this was fairly large, this was of the order of 45 by 45 millimeters, which is far too big to put into one cassette. So we would bisect this particular tissue. So in order to make sure that we don't lose our way, what we do, as I said, we indicate the back of the tissue. I color that with black ink. And then the oral end, I indicate with red ink, and the distal end or the anal end also orientated with red ink. And then I bread slice this whole thing in 2 millimeter sections all the way across. Just to give you an indication, I think we ended up with about 30 odd sections. There might even have been a bit more on this. To give you an idea, it takes about an hour to dissect it, and then another hour to look at it. So there's a lot of time and then probably another half an hour to 3/4 an hour, even sometimes close to an hour actually, doing the report. So it becomes almost a labor of love where one's got to do this. And the important thing is you have to apply that time. And the reason why you have to apply that time is because if you rush through it, you miss subtle features. Okay, so that is the macroscopic appearance. So now what I'm going to show you is just one of the sections of what it looked like. So this is low power 2 times magnification. And what you can see here straight away is that this has a papillomatous appearance to it. Now I use the word papillomatous as an adjective, not as as a noun. So it has this very sort of papillary appearance. You can see these fronds of squamous mucosa, and we can see, for example, if I start at this end, so I spoke about the red ink. So this is red ink on the surface. Okay, it's got a color red to it. And that tells me that that is the margin of resection. And then at the deep margin of resection, if we go here, we can see the black ink, which represents the deep margin of resection. So I'm able to orientate exactly where I am. And in fact, when I lay the slides out on the board of slides, I actually do it in such a way that it builds up a slide image, if you will, of what I saw macroscopically. So what we've got then is we've got squamous mucosa here, which to all intents and purposes is normal. Nothing wrong with that squamous mucosa. And then as we migrate down the epithelium, first of all, just show you here that there may be the beginning of a bit of basal cell hyperplasia that you see there. And then as we move along, we start to see a little bit of intramucosal edema, pericellular edema with a bit of lymphocytic inflammatory infiltration, lymphocytic inflammatory exocytosis. And then as we move along, that tends to get progressively worse. And under lower power, one can see that there's the beginnings of a bit of a papillary architecture, which is starting to become apparent. And that gradually then undergoes metamorphosis if one is permitted to use that term. You can see we've got this basal cell hyperplasia, and then we've got this acanthotic squamous epithelium, or sometimes we talk about pseudoepitheliomatous hyperplasia. And here you can see that demonstrated pretty well. So you can see that nicely demonstrated, this transition from this squamous mucosa there to this squamous mucosa here. Now, accompanying this, there's a dense inflammatory infiltrate, which we'll look at in greater detail just now. But you can see this frond-like appearance. And as we move along, we can see that these rete ridges, and it always puzzles me why we call them rete ridges, because if you think about it, these rete ridges, in fact, are endophytic, not exophytic, but that's certainly the term that we use. So the squamous epithelium has these, what we call bulbous rete ridges. And you can see that well demonstrated here. You can see how they are almost like, we also talk about gourd-like rete as well, which is characteristic of this entity. Now, we know this well from the female genital tract and also from the male genital tract in terms of verrucous lesions. So condylomata, for example, have this typical appearance. Now, in the genital tract, we would talk about the giant condylomata of Buschke and Lowenstein, and if the diameter of those is 5 centimeters or greater, then we would regard that as a verrucous carcinoma. In this particular instance, this is a large lesion. As I said, it's about 45 in fact, it was 28 by 25 millimeters, but the actual lesion itself. But if we look at this here, you can see that we've got this acanthotic squamous mucosa. That's quite a good area here. You can see we've got superficial erosion and inflammatory infiltration with large numbers of neutrophils. And then we've got this squamous mucosa, which is not really maturing as one would expect. If I ask you, for example, to take a mental photograph of that area there, and then if we compare it to the squamous mucosa there in the less prolific area, you can see that the difference between the two areas of mucosae is completely different. So going back then to this area here, and if we look at the basal aspect, we can see, in fact, that now what we've got is this quite incredible basal cell hyperplasia. And if we look at the surface of this epithelium, you can see it's starting to acquire glycogen. And then in the center, we've got what we call keratin-filled craters. And that's, in fact, quite a good area there. So you can see this bulbous appearance to the rete. You can see the basal cell hyperplasia. And in the center, we've got this keratinous appearance. And this picture, in fact, is replicated. This is a particularly good area. And one could put this photograph, for example, in a textbook. But there are other areas where, for example, you've got the same sort of thing that is happening. I want to move back now to this area here and show you that in addition to the basal cell hyperplasia, we've got a few other changes. First of all, the nuclei are larger. They're more hyperchromatic, in other words, darker, and there is irregularity to the nuclear membrane. Now, nuclear membrane irregularity is a cytological feature of dysplasia or malignancy. And sometimes you get little bits of nuclear membrane sort of disappearing. So there's a nuclear membrane there, which is quite irregular. And then the other feature that we've also got is increased mitotic activity. And you can see that some of these mitoses, in fact, are abnormal. Mitosis there, one there, and another there. So how does all this fit together? Oh, sorry, and then before I go, lots and lots of inflammation, lots of plasma cells and lymphocytes in the basal, beneath the epithelium, and then you've got this quite intense acute inflammatory cell infiltrate in with the keratinous debris. So what does this all add up to? Well, this is actually, I think, a verrucous carcinoma. And a verrucous carcinoma is a low-grade tumor. Typically, it grows by local expansion and infiltration rather than direct infiltration as a squamous carcinoma does. So that's the important differential. Is this a squamous carcinoma, well-differentiated squamous carcinoma, or is it a verrucous carcinoma? So its size suggests that it's a verrucous carcinoma. And if we then look, for example, at the extent of the infiltration, you can see that that's entirely confined to the lamina propria. This is the muscularis here. There's no breaching of the muscularis. There's no evidence of intravascular invasion anywhere, and no evidence of perineural infiltration. So I think it's a great case of a verrucous carcinoma. Now, Prakash also mentioned that there were some white plaques, and he biopsied one of those, and this is one of them. And here, you can see that we've got very similar mucosa to that, the edge of that biopsy, or that edge of that resection, where you've got this acanthotic squamous epithelium with a bit of basal cell hyperplasia. So this I think is acanthotic squamous epithelium, and that's why it appears white, because of the acanthosis. There's a little bit of basal cell hyperplasia, but this is insufficient to warrant diagnosis this as a verrucous carcinoma. I think as far as etiology is concerned, the literature, in fact, is a lot of people say, oh, that's all HPV related. That is actually not borne out by the literature. And in fact, we still have to find a probe. The probe that we've been using in the department, in fact, has been discontinued by these suppliers. And these probes, in fact, are very much machine dependent. So I'm at the moment looking for another source to do HPV typing on this. I think probably fair to say that if we go back to this here, that some people may say, in fact, that change there is coelocytosis, and I think one would be hard pressed to deny that. Yes, it does look coelocytotic, but as I said, the evidence, for example, suggests that it probably isn't HPV related. But the proof of the pudding is going to be once we get the HPV typing on it. Interesting tumors. Very few of them have been described. And yeah, Vikash, over to you, and any questions?
Yeah, thanks, Prof. Yeah, so I mean, if you look at the literature, like Prof. Hale was mentioning, there's actually less than 50, some people think less than 30 cases reported in the world of these tumors in the esophagus. They're more commonly found in the oropharynx and the genital tract, so incredibly rare. And if you look at the literature, like he's absolutely right. Most of them are not associated with HPV, associated with tobacco and alcohol and inflammation, but not HPV. So incredibly rare tumors. Most of them are picked up at a late stage. They don't metastasize and invade early, but most of them are picked up at a very late stage in the evolution. Very few reports, I only found one of endoscopic treatment of them. So quite a rare tumor, quite a, unusual finding. But again, I think the endoscopic impression, assessing those IPCLs, was very important to decide the right therapy. And I think we hopefully have given the patient the right therapy. He probably won't be considered for a renal transplant anymore. He's going to probably have to prove himself. And we're going to certainly need to resect the other lesions and keep a close eye on him. but I don't think he was going to be considered for a transplant. Giving him immune suppression is probably just going to make that draw up. At least probably have to prove himself for a few years. But thanks, Prof. Hale. Yeah, that was an interesting case. I must say, I suspected an HPV-related papilloma when I went in, but that mess just didn't look very typical. It's got that cerebral, almost like a little brain, it looked. Not that typical warty, frondy appearance. So it was unusual, and again, very rare. So thanks for that excellent demonstration of the pathology.
Oh, thanks, Prakash, and thanks for that good endoscopy. Certainly I learned a lot about the vascularity. I'd be interested, you say that we shouldn't necessarily consider him for transplantation. I guess that if he's HPV negative, then, we should probably put him forward. I don't know.
I think the problem is the other lesions still have to be addressed.
Yeah, but one would make the assumption that if the big one is HPV negative, that the small ones probably are as well.
Yeah, I think it's going to be a very difficult thing. I mean, there's so few cases reported that there's absolutely no literature in terms of chemo, radiation, nothing on these tumors. So it's going to be a very, very, very difficult call. And there's no long-term follow-up on these patients as well. So he's probably going to have to prove himself for a while before he's considered. I don't know. We'll have to take it to the nephrologist and the transplant panel, and they're going to have to make a decision. I doubt he would be considered a candidate. Maybe Bilal can, I mean, through his transplant experience, similar to what the livers and the kidneys.
Yeah, so there are international registries for these sort of things. And I think it would be important to consult, for at least for the nephrologist to put a consult in. The fact that he's HPV negative is somewhat reassuring, but nonetheless just raises the matter, for all of us dealing with immune suppressants, the HPV vaccine is available. And if you're going to be immune suppressing your your patients, please consider administering the vaccine. I know certainly in the post-transplant setting, we see some really horrible verrucous lesions in individuals that have not received the vaccine. So yeah, it does. The fact that he's not really, playing by the rules does make it a bit more difficult in terms of deciding for transplant. So I agree with you, Vixie. The good thing is that he possibly has some time to wait on, and for us to see what his natural history progresses as. Okay, I'm not sure if there are any other questions. Is anyone else with a raised hand, or if I can encourage people to type their questions in the chat, and I can help facilitate those as we go along. But while you think of any questions, Prof, shall we start with the next case?
Yeah, thanks, Bilal. So I've actually got 3 cases of the same thing. So, I'll give you a potted history of all 3 cases, but it's basically a common theme. And the one thing that I'm always amazed at is how frequently we see, these pathological changes, and these interesting cases that everybody is finding. And thanks very much for sending them to me to have a look, because certainly I learn a lot, and thank you. So the first patient then is a man of 41. He presented with decompensated cirrhosis. He had ascites. He also had episodes of spontaneous bacterial peritonitis and the possibility of autoimmune hepatitis was being considered in the etiology. His liver function at the time showed a total billy of 14, the direct was 7, alk phos was 156, the gamma was 162, ALT 50, and AST is 63. His total protein was 59, and he had an albumin of 34. His serology for the hepatotropic viruses was negative, as was the serology for autoimmune disease. Although apparently, although I didn't see it, his anti-smooth muscle antibody was also found to be low positive. But what was interesting was that he was also found to be heterozygous for H63D. And the serum iron was 16, the transferrin also 16, and the ferritin of 471 with a percentage saturation of 50%. So a liver biopsy was done, and for a suspected diagnosis of autoimmune disease and autoimmune hepatitis. Okay, so that's the biopsy. And what we've got straight away, you can see that that this is a cirrhotic liver, as you see there. Broad bands of fibrous tissue. And if we, and I'll come back to that, if we look at the Sirius red, which is a collagen stain, you can see that that's well demonstrated. You can see these nodules of regenerating hepatic parenchyma embedded in broad bands of fibrous tissue. If I go back to the H&E, and move to the areas of fibrous tissue and have a closer look at that, I can see that there are significant numbers of lymphocytes and also plasma cells. And if we look here, for example, these are clusters of plasma cells here. And then when we see that, the first thing to think about is, could this be autoimmune hepatitis? Now, interestingly, his autoimmune markers, in fact, were negative. But as I said, there was this possibility of a low positive for asthma, and a few more clusters of plasma cells down there as well. So what this is looking like then is a cirrhosis with a probable cause or etiology of autoimmune hepatitis. And I must say, I'm finding it, from my own point of view, quite difficult to understand the relationship now of autoimmune hepatitis, positive serology in the presence of cirrhosis. And I think Bilal, perhaps that's something we can also discuss, because I think from your point of view, you accept an element of autoimmune positivity in patients who are cirrhotic. I don't have the immunoglobulins to hand. So bearing in mind his H63D mutation, this is the iron stain. So the pearl stain, and this is positive. But what I want to really show you is two things. First of all, this area here. Now that is what we call tram tracks or tram lines, where the hemosiderin is deposited in the hepatocytes along the cellular membrane. And because you've got adjacent hepatocytes, you get this what we call tram track appearance. You can see it there, but I think that's nicely demonstrated there. And I think there's also a suggestion of it there and there. So if we see that, then we suggest, could this patient have hemochromatosis? And that is something we see, I wouldn't say rarely, in fact, probably relatively frequently, I suppose, bearing in mind that we are a referral center for liver pathology. We see it more often than most centers. But that's fairly typical. But the other thing that I'd also just like to demonstrate to you is the relatively small amount of hemosiderin in these hepatocytes. And it is focal, it's there. We haven't got much in the way of hemosiderin there. And for example, in this area here, also minimal hemosiderin. And I think that that would fit with this H63 gene mutation. Going to the copper-associated protein, the ornithine stain. And the ornithine stain is interesting as well because that shows increased quantities of copper in the paraseptal hepatocytes. And just to pick up it here, and you can see, for example, this is the fibrous connective tissue septa here, there, and this is the copper which is present in the cytoplasm of the paraseptal hepatocytes. And you don't see it anywhere else. It's always adjacent to the fibrous connective tissue septa. And more copper there. Now, small quantities like this here, I think one could accept because patients with cirrhosis generally are cholestatic. But when it gets to this sort of quantity here, starts to get a little bit more than one would normally see in a patient, for example, with autoimmune hepatitis. And we could discuss the relationship of copper metabolism and iron metabolism at the end. So that's the first patient. So I would say that if you like, that would be what one would expect, for example, in a patient who has heterozygosity for H63D. Right, this is the next patient. And the story is very similar. 61-year-old man. He was found to have abnormal liver function. He also had idiopathic pulmonary fibrosis and type 2 diabetes. But his enzyme showed a gamma of 474, an AST of 57, and an ALT of 57 and an AST of 85. His ferritin was 2039. He was heterozygous for H63D, and his ANA was positive at a titer of 1 in 160. And imaging of the liver showed features of cirrhosis. So this is the H&E. As you see there, it's a cirrhotic liver. If we go to the reticulum, you can see the typical appearances of cirrhosis, architectural distortion, trabecular disarray of the reticulum framework, twinning of hepatocytes, more lobular disarray there as well. So pretty typical for cirrhosis. And then the Sirius red showing you the same thing, but in technicolor with these regenerating nodules separated by the fibrous tissue bands. Sirius red's a lovely stain to demonstrate collagen. Easily done, seldom fails, if ever. And then this is the pearl stain. And the pearl stain was interesting because in this particular instance, there was more iron. And you can see now that, in fact, the concentration of iron in the hepatocytes is much greater. It's more widely distributed. It's present in most of the regenerating nodules and fairly significant. And in fact, from a Scheuer grade point of view, I think I've called this a grade 3 to 4. And how do we do that? Well, we take the granules. For example, if we can see that, this is what's called high dry under 40 times lens. So if you could only see the granules under 40 times lens, it's a grade 1. This is the next lens up. You can still see them. So that would be a grade 2. And then that's the next low power. And I can see it on the microscope. You can just see it there. So it's about a grade 3. And it just gives a ballpark figure as to the extent of the iron overload. In this particular instance, it didn't show much in the way of tram tracking, but certainly thought it was unusual to have so much iron in the presence of being heterozygote for H63D. And then when we go to the copper, a very similar picture. Once again, significant quantities of copper in the paraseptal hepatocytes. And you can see there, in fact, there's more copper in this biopsy than there was in the previous one. So that's another patient then with H63D gene mutation, with iron overload and cirrhosis and increased quantities of copper-associated protein. Then the next patient is another very interesting patient. So this patient was a 39-year-old man, retrovirus positive, had been on therapy but had recently stopped. His liver enzymes showed total bili of 120 with a direct component of 94. His ALP was 149. His gamma was 115, ALT 132, and AST 263. A couple of other interesting things. His IgG was 33. He had an IgM sort of top end of normal, an IgA top end of normal of 3.4 and an elevated IgM of 4.6. A couple of other things that were also interesting was that he had he was hepatitis B surface antibody positive. He was hepatitis B core antibody positive, and he was also hepatitis C positive as well. And as I said, he was also HIV positive. Or is also HIV positive as well. So I had a whole lot of things going on that could certainly cause significant liver pathology. And there was something else that I wanted to show you as well. His serum iron was 31. His transferrin, this is a different lab, was normal at 1.3. The ferritin was 3,079 with a percentage saturation. And as we've said before, sometimes the maths goes a bit wrong here. It had a percentage saturation of 111%. Platelet count of 39, and his albumin was also down as well. His albumin was 29, or in fact 20. So his liver biopsy, certainly when one went through that, certainly sounded as though it was going to prove to be interesting. And interesting it certainly is. And I'm sorry the section is a little bit thick, but it certainly shows you a few things. First of all, I think it is cirrhotic. If you look at these areas here, you can see that we've got hepatoparenchyma here, and also down here. And then if we move across here to the portal tracts, we can see that there's a dense lymphocytic inflammatory infiltrate. And in the middle of these, you've got bile ductules and proliferating bile ductules. there's a hepatic arteriole there, and I think this is the remnants of a bile duct which has been overrun by lymphocytes. And that is typical of hepatitis C infection. All lymphocytes, not much in the way of plasma cell infiltration. And then if we look at the hepatic parenchyma, we can see that we've got the sinusoidal bead-like infiltration by lymphocytes, which is another feature of hepatitis C. I didn't see any ground glass hepatocytes of hepatitis B infection, and there was no evidence of any fatty infiltration, which is a feature of hepatitis C. But in some areas of the biopsy, there was this here. And you can see that now we've got a patient who's got massive iron overload. This is all iron, intracytoplasmic iron. And if we go to the iron stain, you can see that there is severe iron overload. This is Scheuer grade 4. And you can see the tram tracking that is present. See if I can find a nice example of tram tracking. So there's a bit of tram tracking there. And said severe iron overload, Scheuer grade 4. And he's also got lots of copper. So this is the third case. And I thought it would be interesting to do this from a couple of points of view. Here you can see all the copper, lots of copper in the paraseptal hepatocytes. Again, all this copper-associated protein. And I thought it quite amazing that we've had 3 patients with H63D heterozygous mutations. They're not compound heterozygotes. They are pure heterozygous for H63D, showing quite significant, or 2 of them showing quite significant iron overload, and also copper-associated protein. And when we've discussed this in our meetings, we've said that the H63D gene mutation is quite a benign mutation, and that if they're heterozygote, they shouldn't have severe disease. So I asked Bilal and Chris if they could comment on that. So I thought it was interesting, and we can briefly talk about the relationship between heavy metal copper metabolism and iron. So Bilal, Chris, over to you guys.
Go, Bilal.
I was gonna let you go. In terms of the H63D, it's generally thought not to be all that pathogenic. Of course, remembering that with a lot of these, you do have a degree of variable penetrance. And then when it comes to copper metabolism, there has been a lot of associations between the hemochromatosis gene defects, which occur then on chromosome 6, as well as the ATP-B7 Wilson's disease gene, which can sometimes also be affected. I think we've picked up 2 cases now where we've found heterozygote Wilson's plus heterozygote hemochromatosis in our meetings thus far, which has been quite fascinating.
Yeah. Martin, thanks, Bilal. So H63D, as you've said, Bilal, on its own does not cause liver pathology and is not associated with iron overload. But in the presence of other etiologies, it certainly may accelerate or aggravate the progression of liver disease. And the one etiology that you've really got to consider is alcohol. Alcohol and heterozygosity for the H63D gene mutation, I think, is not good. We see a lot of fatty liver with elevated ferritins, and when we look for PCR for the mutations, we often find heterozygosity. If we don't biopsy those livers, and if the biochemistry is abnormal, we tend to venisect them. So in all these three patients, Martin, you can see that there often is, except for the last patient, there might be discord between what we see biochemically on the liver transaminases, what we see in the iron metabolism, and also what you see histologically. But the principles are pretty much clear. Unless H63D heterozygosity is part of a double heterozygosity, and there are also other, we're only checking for 3 of the gene mutations, the ones that are associated with Caucasians or Celts. There might be other mutations that we're not aware of, and indeed the H63 gene that heterozygosity that we're picking up may be part of a double heterozygosity that we're not aware of. Essentially, the principles will be the same. You need to consider venesection, you need to screen for HCC, and you've got to look for an underlying etiology.
So I think that brings us to this concept of metabolic hyperferritinemia, which is where you may very well see the elevated ferritins associated with, for instance, fatty liver disease. But then just it is fascinating looking at the mechanism of iron overload when it comes to alcohol. And just as a quick explanation that just clicks in my head is that alcohol is an inhibitor of hepcidin. So instead of having a hemochromatotic state where you have the complete deficiency of the protein, in this instance, it's an induced deficiency by the alcohol-associated inflammation. Resulting in hepcidin deficiency and then iron overload. I see Sandy, you are on. Would you like to comment, perhaps? Sandy Musenye?
So while we're waiting for him, so Bilal, do you venisect your patients? Will you venisect these patients?
Oh dear, Chris, you just broke up a bit. I didn't hear the question.
Sorry. Would you venisect these patients, and do you venisect your heterozygosities in MAFLD?
So no, not the standard MAFLD patient. I actually use the ferritin as a marker to see, along with the weight loss and the various medications, to see are they improving. And I use the ferritin as a marker to see if that starts coming down, then I take it that the inflammation is coming down in the liver. If, however,
and if they were
had
MASH?
a biopsy and you see, well, that's the metabolic associated livers that I'm talking about. In alcohol, it does make it a little bit more tricky because a lot of these patients when they're that advanced, they're often almost self-venisecting and already have some degree of blood loss. So I think you a station and you have that picture specifically with that intracellular iron and that tram tracking that Prof. Hale pointed out, that is the sort of patient that I would probably want to venisect, where you've got a somewhat harder evidence to say that you've got parenchymal iron overload. But I don't do it standardly now. It has been looked at as a therapeutic option for specifically in metabolic associated steatohepatitis, and was not shown to be beneficial.
And then the other point is that copper accentuates or facilitates iron absorption.
Yeah. The whole relationship between copper and iron, I think, is still got to be unraveled, Chris. As Bilal said, the heavy metal metabolism seems to go together, that if you get metabolic dysfunction with one, there seems to be an accentuation of the other heavy metals, and particularly copper. But also, we also need to remember as well that with copper, with cirrhosis, because copper is a cholestatic sign of cholestasis, chronic cholestasis, you may expect a small amount of copper.
Yeah, as a second effect, yeah.
But it's
very good cases.
Yeah,
very excellent cases.
We don't have all the answers, I'm afraid. Not yet.
Yeah. Just want to see if there are any further questions from anybody else. I see the chat doesn't have anything pending. I'm going to start just rounding up. I'd like to thank then Cash and Prof. Martin Hale for their presentations. They really are fantastic, and Vikash, well done. You're doing absolutely amazing work. Really, really good job. I'd like to thank them. Well, obviously, so that's thanks to the speakers, but thank you to the ECHO team at the University of New Mexico, as well as the India team. Remember that these recordings are available on the Gastro Foundation website. Thank you once again to the Gastro Foundation and our various sponsors. You've had a bit of a taste of upper endoscopy with Dr. Lala, and next week's Gastro Echo will be on upper endoscopy. So please join us then. Thanks everyone for joining. Last chance for any questions before I close up. Doesn't look like we've got any. No one's hands are up. Had a quick look. Thanks again, everybody. Have a good evening. Bye-bye.
Thanks.
Thanks so much. Thanks. Time went very quickly, Martin. Excellent cases. Thank you. Thanks, Vikash. Thank you.
Thanks for asking me.
Thanks, Bilal. Yeah.
Cheers then.
Thanks then. Cheers. Bye.